Well, welcome back to the AAPS Cannabis 360. My name is Adam Greenblatt. I'll be moderating a panel here with Peter Hugin and Cody Peterson about the entourage effect. So I'll invite Cody to introduce himself first, and then Peter can go after, and we can get into the questions. How about that?
Absolutely. Hey, I'm going to try to match your excitement here, Adam. My name is Dr. Cody Peterson, and I'm super excited to be here. I'm a pediatric pharmacist and cannabis science expert. I got my master's degree in cannabis science and therapeutics. I'm also chief science officer of the Canigma, and I like talking about all things endocannabinoid system, which certainly will come into the conversation today.
The Canigma. So are you a cannabis riddler? Do you have any good cannabis riddles?
It's cannabis enigma, actually. So I try to talk about and address questions that people have that unfortunately, when they go to Google, they can't get good answers to.
Right. Cool. All right. Well, Peter, how about you? Tell us a bit about yourself.
Thanks, Cody. I am a medicinal chemist by training, teaching in pharmacy right now. I got into all this through a general interest in the supplement industry, and there's obviously a lot of crossover between how the supplement industry is handled on the federal level in the states. And I should throw that out there right now. Most of my understanding of the legislative side of this and the regulatory side is US based. So I know a lot of this is going to be going out to Canada, but I can really only speak to what I know about the US. And cannabis is kind of treated by the states like a dietary supplement, even though the federal government refuses to recognize it as such. So it's kind of in this weird space. But you see a lot of the same red flags of how the industry is run and claims that are being made. So I kind of got drawn into cannabis from that angle and looking at it with an understanding of the chemistry and the pharmacology. So yeah, I kind of got into writing some articles on this.
Cool. Well, I can fill in the Canadian perspective as we go along as well. I'm more familiar with the Canadian regs than the mishmash of American regulations and or lack thereof. Let's talk about the entourage effect. I pose these questions to both of you. You guys can jump in, whoever wants to go first on either question. But so on the entourage effect, the entourage effect is commonly promoted as a verified phenomenon, as opposed to a hypothesis. It forms the backbone of most cannabis marketing. What do you guys see as problematic in, say, like exaggerating the therapeutic potential, or like talking about the entourage effect as though it's like, as though it's like proven in concrete? What are some of the hazards here in how we discuss the entourage effect?
So we're going to get to both chime in, and I know Peter wrote the book on this, or at least the article on this, and I think there's a lot to be said about the misleading of the industry, but I don't think it even starts with the entourage effect. I think this is beyond where the misleading or the sort of confusion around cannabis begins, which is really indica sativa hybrid. And is where like the consumer immediately falls into like, okay, I'm not really actually sure what I'm dealing with. And when we get into the topic of the entourage effect, that I'm sure Peter will touch on, this isn't a new concept. It's like plants, can work better than the extract of that plant, but also plants as a general whole have things that maybe we don't want, or we must, consume in a way that we don't want. And a lot of the times, not necessarily in cannabis, plants contain harmful things like terpenes that are actually going to cause liver damage or other problems. So humans, when we've used these medicines, have found ways to extract them and separate them. In the case of cannabis, there aren't too many of these hazardous components, and this is one of the most studied, at least in recent years, herbs. Unfortunately, it doesn't look like any of these terpenes at any of the doses that you could get from consuming cannabis. Natural cannabis anyway, would be approaching that level. Of course, if you're in Southern California, most of the cannabis you buy in pre-roll form is no longer even herb. It's herb reinfused with something else, THCA and some terpene isolate Lord knows that the vape cartridges don't just contain pure cannabis either. So there's
Yeah.
there's a lot to be unfolded. But I just want to kind of start out with like framing this as like this. I don't think this is the chief misleader of the world, because the truth is cannabis does have varying effects, and we don't understand why completely, but I promise you it's the complexity of the plant, but also, and importantly, and not talked about enough, the complexity of you and your endocannabinoid system and all of the things that make it thrive or not thrive. So I'm going to kick it over to Peter for his comment.
Yeah, Peter, what do you think are some of the hazards here about how we talk about the entourage effect in cannabis marketing, and general, all the entourage adjacent stuff as well?
Yeah, I mean, Cody touched on a lot of the big things here that we're going to hit throughout a lot of these questions. I want to first, there was an issue of legislation, like, what's the way to go forward with legislation in this question as well. Just so people kind of know where I'm coming from, and I think we're going to all be on the same page with this. So, like, as far as legislation goes, at least in the States, the decades-long prohibition is asinine and it's pointless. I mean, people are using this stuff. I would say that it would be appropriate to deschedule it, at least decriminalize it, maybe even legalize it. It'd be nice to see like a reliable roadside impairment test before you go to full legalization. And that stuff's coming. Once you decriminalize it or even legalize it recreationally, let people use it however they want. If they find some kind of therapeutic benefit, knock yourself out. There's no reason why you shouldn't have access to the plant. It'd be nice to see, I mean, if you're dealing with minor anxiety, minor sleep disturbances, you can kind of self-treat. If you're dealing with childhood epilepsy or cancer, you probably want to be talking to a healthcare professional like Cody or a physician who has experience in the field, and not a bud tender. So it'd be nice to kind of
probably. You definitely do. You definitely do, because you're making pharmaceuticals. Not exactly. Sorry, I feel compelled to say there's not even a probably there. We're talking about CBD in particular. This is a clear drug interaction. And the only person equipped to talk about it is, frankly, not even the physician usually, it's the pharmacist.
Yeah, I mean, there needs to be more education out there, absolutely.
Yeah.
And there's not enough guys like Cody out there involved in this. As far as regulation of it, I would say I'd like to see it regulated more like tobacco at this point, right? You regulate the potency, you regulate the purity, because there's too many problems with heavy metals and other things being pulled into the plant from its growth conditions that you can't easily control. Regulate and stamp the boxes with realistic health concerns. Like, I mean, not ridiculous reefer madness stuff. Like, if you smoke this, you're going to start dating a jazz musician, like real health concerns. And then prohibit unfounded therapeutic claims, like as you do with tobacco, until
and
you
herbal supplements, right? Like, you can't say that this treats cancer on any herbal supplement, as you shouldn't be able to say on your RSO.
Well, I think invoking tobacco is interesting because, if we're talking about legislation to control health claims and stuff like that, like tobacco, how do you feel about just the promotion of cannabis in general? Because like the American and the Canadian tobacco contexts are very different, but like I feel like one big part of tobacco legislation is control on marketing and promotional efforts. So how do you guys feel about that as it relates to health claims and generally speaking?
Yeah, I mean, there's one of the problems that I see is, like, in the state laws in the US, you can't, like the supplement industry, you can't say in your marketing or your packaging, it treats this. Like, you can get away with what are called structure function claims, which are vague claims of it promotes health or promotes GI, improvement, that kind of stuff, which doesn't tell you anything. But what you run into is if you go on to like Leafly, or you go on to High Times or any other major online resource for information, you'll see an op-ed piece on what strains or chemovars, however it's phrased in the op-ed, is good for treating cancer. And then you'll see a button up at the top corner of that page where they're selling stuff, or you've got somebody in the sidebar advertising products that just so happen to match up with what the op-ed is telling you is good for you. So they get around the law by just linking an advertisement to an opinion piece. And you can't really do that in tobacco, and you shouldn't be able to do that, right? I mean, it should be pretty straightforward of what you're allowed to claim.
I mean, the stuff you can still do with tobacco in the US is mind-blowing. to me as a Canadian. We have
well,
gone
maybe in the US, but if you consider if around the world, I mean, I'm not an expert on this. I'm not. This is not.
Oh, around the world too. I mean, like Canada has gone. We've gone to like the complete extreme end of cigarette regulation. So like, even when I go to the States, like we can't in Canada, we can't even display cigarette packs behind the cash of a convenience store. So like when I went to Colorado and I saw Marlboros. I just went to a convenience store and I saw all the cigarette packs, and that was like, oh my God, it was a trip back in time for me. You know. So.
Yeah, I don't know if we need to be that terrified in terms of placement of cannabis, but like again, the whole idea of potency, purity,
truth in labeling, absolutely, regulation that is not overbearing, but that at least has some sort of randomized check some way to capture these bad products that are making their way into consumers' bodies. These heavy metals, this isn't a joke. There have been numerous times where they've tested products that have been sitting on shelves and they've accumulated heavy metals. They think it's coming, this happened in Florida, from the paint that's on the little dropper. It's being absorbed into the oils from the paint because they got some cheap paint from some whatever Amazon or Alibaba dealer. So like we have to be really mindful that if we're going to treat this like that we can regulate this in somewhere in its own. And frankly, what I think that means is like kind of going bigger is take not tobacco, like don't regulate it like tobacco. This does have therapeutic value and it does have nutraceutical benefit. We absolutely can say that just from anecdotal, like just surplus. Like there's just so many people saying this helps me that we can't just dismiss it. Unlike tobacco, which is killing people. So like they can't be the same. We need to create under the FDA, it's this cannabis Center for Cannabis, and not actually, I'm gonna take that back. And I think it should be its own division that's regulating cannabis. I don't think it should be the FDA. The FDA does drugs. This is not that. This is an herb, put it USDA, whatever you want to do. But we have to create a different structure and it needs to come now and then the rest can come. But this interstate stuff is not going to work. Consumers are not going to be protected and it's not going to foster good business. Look around the country. Cannabis companies are flopping in most states that have turned online. Not everywhere, but there's major issues afoot, as you know, Adam. Even the large companies, too big to fail, are struggling. So,
yeah. I mean, I would push back a little bit on the regulated like a supplement because the idea that herbs are not drugs, that's a legal definition. It has nothing to do with pharmacological reality. The whole
no, there's terpenes in all of the herbal supplements, and many of them that are creating and interacting with our adrenergic nervous system and our GABA receptors. This is in all of the herbal supplements. So,
but they're all drugs, and they should be regulated like drugs.
No, drugs are made by men. These are made by plants. I mean that. Fentanyl caused an epidemic. Heroin caused an epidemic. Opium was a problem. There was not people dying. I mean it. Opium is a plant derived. It is not as separated into morphine.
I know what opium is. Yeah.
Yeah, but it contains multiple alkaloids that are naturally actually protective from these overdose effects that naturally don't promote the addictive qualities of this drug. We've actually taken thebaine and turned it into buprenorphine. This is a derivative that we've used to treat opioid addiction. So don't dismiss this. Plants naturally do this. And we see this in cannabis. We see THC produced right alongside CBD, particularly in natural varieties. And there's a mediating effect. And that's probably the one entourage thing that we can stand by with some degree of certainty, that CBD regulates the psychoactivity of THC, or influences is a better term, and it's dose dependent.
Yeah. And
that is the second question. If we want to move to THC and CBD, sure. Yeah, sure.
This because bring it full circle. Like we talked about the problem of fraud, but the problem of harm is also there as a big issue here. Let me bring up a paper from Mieri and then one from Mizzou's real quickly.
Dedi Meiri is a very influential Israeli cannabis researcher.
So here's a paper from the Mieri group. And they're looking at a variety of different extracts, right? These are different chemovars against a variety of different cancer cell lines.
In vitro.
Right out of the gate here, that you get different effects. So this idea that you can say as an overarching generic umbrella term that the Entourage effect delivers some benefit it's pretty clear here that that's not true. Some of them, yeah, but some of them, they
Wait,
don't.
time out. There's a lot of variability between each product, suggesting there
Right.
is an entourage effect.
Right, but the idea,
but the entourage effect is not always inherently
Consistently
beneficial. It's not.
against these
It's
cancers.
framed. It's framed as only beneficial. It's framed as universally superior to single molecule pharmacology and pharmacy, but like that's where it gets inaccurate. Sorry, carry on, Peter.
There's the marketing that where it's a problem.
Yeah.
From the same paper, you look at extract number 7. This is doing a really good job of killing normal airway epithelial cells. So how do you know that your entourage isn't doing this? And then if we go on to the next paper by Mazuz, right? So they did an extract, they separated it out into fractions. Here's a couple of fractions that they combined together for their studies. Here's a zoom in the red here of CBD and then some stuff in the baseline. This is 98% CBD. There's some terpenoid content, some other cannabinoids. When they look at their data here, here's pure CBD, here's their control, right? This is cancer cell viability. 100% growth is by definition the control. CBD is preventing about 50% of that cell viability, which is great. When they give one of their combinations of their fractions of the different entourages, you get this effect, which seems to be fantastic. The problem here is, here's one of their other collections, one of their collected entourages, which is actually giving you about 160% of growth, which means that this is actually fueling the growth of these cancer cells. If you're going to tell me that this is real, you got to contend with this, right? There's no way to tell just by looking at a chemovar, because we don't know what the individual components do. We don't know what the combinations do. There's no way to say that it's going to bring a net benefit or that it's even safe.
I would like to point out something.
Yeah.
Notice to the right, your Fs, your EFs, and et cetera. Now, these look to be multi-component polypharmacology drugs over here. I see some entourage effect over here as well. Would you agree?
That seems to be what they're reporting.
Well, I mean, hold on, sir. So if you're going to say F is true and A is true, then we ought to say F, F, E, F, and F are true, which
Fair
is
enough.
saying there is an entourage effect that is beneficial when CBG, THC, CBC, we see this cell viability, this cancer improvement. So look at that. When you use multi-cannabinoid components, you saw a benefit.
And the asterisk to all of this here is that these are in vitro cell culture experiments too.
And one cancer type, right? That's really, really important to contextualize in this whole conversation. Is cancer is one of the most dynamic, complex, and unique diseases that we deal with as healthcare professionals. And as such, it's going to be this variable regardless of what treatment you're using. So it's not always the best example.
But
Well, the cannabis industry likes to talk about cannabis, or talk about cancer, like
particularly
it's
our
one
RSO
thing.
makers. Yeah.
And they
Let's
like
let's not get too far into the RSO stuff. Anyways,
to pretend that it's always a benefit, and there's clear evidence out there that it's not always a benefit, and you cannot predict what any given chemovar is going to do until you actually study the exact components of the plant. Is the point of this? Yeah, some might have this benefit, some might be killing cancer cells. I would tell you the whole thing is probably artifactual. And because it's in vitro, it's probably concentration dependent solubility effects is what you're seeing there. But again, if you're going to tell me that those are real entourage benefits, you got to contend with the data points from the same data set that show that you're actually fueling cancer cell growth with some of their entourages.
Yeah, it reminds me of one thing I like to bring up in the Rick Simpson oil with the zealots is that paper that showed THC can actually increase the growth of HPV related cancers, right? They found that like presence of THC actually accelerated the growth of HPV positive head and neck cancers, which blows the RSO claims out of the water, right? It's not even to do with the entourage effect. That was just single molecule. This isn't a miracle kind of a trial, right?
Well, don't tell them that RSO is not full spectrum, because that's just going to upset people.
I'm all about upsetting the zealots. Anyways,
look, I think that's the whole problem, is this whole idea of full spectrum. This word is nebulous, right? What does it mean? I wrote an article on the Canigma, which, by the way, we're trying to walk this line between telling people the truth and advertising, because the world runs on advertising and there's no getting away from it. And
Well, in fact, like what you're doing is you're doing education, and education is advertising. Education is now a catch-all term. In cannabis, education doesn't just mean education, it means marketing, right? In Canada, especially in Canada, where we have super restrictive promotional regulate, like we cannot promote cannabis, we cannot incentivize people to use cannabis. And what's happened is that people just call marketing and promotion education. So
and everybody's an educator.
yeah, like, oh, I'm going into the dispensary to educate people today. Like, you're going into the dispensary to upsell your weed drink or your vape pen or whatever, right?
Business development, it's not sales.
Right. So on THC and CBD, THC is CBD an antidote for THC? Let's get that out of the way before.
Antidote? Absolutely.
Yeah, is it an antidote
way.
to the adverse effects of THC? Can it counteract some of the adverse effects? Like, how strong is the evidence there?
That's a different. Okay, so an antidote is atropine when you're being poisoned by organophosphates. Antidote is Narcan that you put in someone's nose and they come back from the dead and say, "Oh my God, I don't feel good." And I see this regularly. Well, thank God, not the organophosphate poisoning. But this is a thing, right? And that's an antidote. CBD cannot do that because it doesn't engage with the receptors. In fact, CBD barely engages with the CB1 and CB2 receptors much at all. In fact, there's controversy around this topic, so I'm not going to get too deep in the woods. But no, and I don't really ascribe to put some CBD under your tongue. Not really. I don't ascribe to put some CBD under your tongue when you're too blitzed, and it'll rescue you. Could it help a little? Maybe, but I think anything that you're giving yourself to be medicine could probably help a little bit. So that's one of the times where I might go placebo. But I do strongly ascribe to ratios. And when THC and CBD are simultaneously engaging around the cannabinoid 1 receptor in particular, we have seen in numerous human studies that there is a ceiling effect where the intoxicating properties of THC appear to be lessened. Now, there are other studies, especially rodents, that have shown that at certain doses or certain ratios, CBD can even amplify the intoxicating effects of THC. So it is not as cut and dry as it's all that. It's all about this spectrum of ratios and activities, all the way over to hemp, right? Your 40 to 1s, your 50 to 1s, CBD to THC, to your now, commonly.
You don't think that ratio stuff gets a little bit too granular? Do you think that people are reading too much? This is a sidebar, but there's so much, I got this 27.5 to 1.3 ratio tincture. Like, do you think that it gets just granular to the point of absurdity with the ratios?
Of course. I think taking anything out to the third decimal that came from a analytical laboratory is pretty ridiculous too. If you think about the accuracy of these instruments, to take it even to 1 decimal is kind of dumb. Just maybe 1 decimal point. Yes, but I don't think it's dumb to utilize ratios as a way to titrate to the effect that you're desiring, particularly when applying medically. And I see this. All the healthcare professionals that are using cannabis are leveraging these ratios and minor cannabinoids, like we saw, might be beneficial in that last case.
Yeah, and I would tell you there's just as many papers out there in human subjects, several of them, that suggest just the opposite. Either they don't see an effect of CBD mitigating THC effects, or some that actually end up amplifying or augmenting the unwanted effects of THC when you add CBD. Now,
those must be pretty few and far between. I haven't read a lot of those papers. Amplifying which negative effects, Dr. Coogan?
So a lot of it is framed in terms of the intoxicating
Tell
effect.
us more about your confirmation bias, Cody.
Well, look, we have our own, again.
Sorry. I know. Sorry. Let Peter elaborate. Let Peter elaborate. Sorry.
All right. Yeah. I mean, I can rattle off some papers here where you'll see this, where you see greater adverse effects being reported in the CBD THC combination group. Johnson 2010, Kilestein in 2002 are two that I've got in front of me right here. I also got a Solowich paper I'm going to bring up in a
So
second.
in the first 2 hours of intoxicating effects, we saw slightly enhanced maybe anxiety or intoxication around driving. I also saw a recent 2020, right, 10 years later, we saw a great review on the 40 to 1 hemp that just came out that said when you smoke this, a whole 1% THC, that you didn't actually get intoxicated while driving, despite having blood concentrations that would be considered intoxicating. So we have a lot of, look, here's what I'm going to say. This is the most commonly used drug around the world. We don't have to say, oh, well, this paper of 42 people said that there was this minor thing. We know that this is doing something. We just don't know to what extent and where the claims are. But I just talked to too many people who are medical professionals practicing that use this to be like, oh no, it's just not enough research to say there's no effect.
It's an appeal to authority, and I'll talk.
Right, but there's both sides, right? You got to see that there's papers on both sides here.
Right,
yeah.
that's the issue.
We get that.
We're addressing
that's what we're talking about.
Yeah, we're addressing the claim that this is expected to be a universal phenomenon. It's beneficial, is how it's marketed. And it's clearly not the case when you look at the data. And the data is much more important, I would argue, than anecdotal evidence. And we'll get to that in a second. But let me bring up a second paper here by Solowich, or a third paper. So this one is interesting because I think everybody's seen this. This is a few years old, where they found that 8 mgs of THC had particular effects. If you added 4 mgs of CBD, so low dose CBD, you actually amplified the intoxicating effects of THC in inexperienced users. And if you had a high dose CBD, you mitigated those effects. All right, and here's their data set. So here's pure THC in the middle. Low THC CBD, you actually get worse objective and subjective intoxication.
A lot of variability on that first line, though.
Did they do blood level? Did they test blood levels in this study?
And that's the beauty of this one. So here's the high CBD. You're actually suggesting that it gets better. So here's their data table. So one of the big points here is that if you just skim the abstracts of a paper like this and lots of others, the author's conclusions are that high dose CBD mitigates the intoxicating effects of THC. However, when you look at their own data, take a look at down here. After pure THC or with the low CBD added, you're getting the same basic amount of THC in the blood, about 90 nanograms per mil. And then here's some common metabolites. If you come over here to the high dose CBD, you get about 1/3 of that THC concentration. So it would make sense that you're going to get fewer intoxicating effects if you're delivering 1/3 of the dose. So the question is, why are we getting 1/3 of the dose? These are blood levels that are drawn 1 minute after inhalation of a vaporized product. So this is not metabolic. This is not metabolic. There's no metabolism. These things are so lipophilic that they're going to get into the lungs through passive diffusion. There's unlikely to be any active transport that's being inhibited here either. However, you look at up here, there's a little superscript, which is described down here. This group's own studies in the past had found that if you add high dose CBD to this volcano vaporizer, it inhibits the vaporization of THC. And they actually had to increase the dose of THC to try to get it up to an appropriate delivery, which basically negates the validity of this data point. But the big take home here is what you're clearly seeing here is that this is a physical drug delivery problem. You're just not delivering the same amount of THC, and they've seen this in their other research. They know that this is what's going on. Yet they're reporting this as a mitigation of the intoxicating effects of THC, but you're just not putting the THC into the body. So this is not an entourage effect, this is drug delivery. So all we can really walk away from this paper with is some data that suggests that CBD in a range that you're going to commonly find in smoked chemovars or commonly available chemovars actually makes these intoxication markers worse. So again, this idea that we know that CBD is going to improve what we see with THC and get rid of some of the stuff we don't want to see, it just doesn't shake out.
It's not cut and dry.
In the data.
So I didn't.
My recollection of the CBD, from what I recall, is like the idea that CBD reduces the adverse events from THC stems largely from the Sativex clinical trials. I believe, if I recall correctly, the decision even to include CBD in the Sativex formulation came down to a comparison of symptomatic relief versus adverse events. And they found similar symptom relief in the CBD group, but fewer adverse events.
Yeah, we can.
I don't have their clinical trial data in front of me, but that's what I recall from, from attending cannabinoid clinical conferences for years and talking about Sativex and
certainly
Ethan
Russo's, like, he leans heavily into that data set. There's no doubt, because individuals who are on the other side of the table trying to refute him are saying, well, I need it from clinical trials. I can't take your anecdote. I can't handle this. I need real trials. So you're forced into that camp. But here's what I want to, I guess I didn't prepare a study, but there are good examples of, yes, volcanoes, but also, there are smoking studies that have been done. And there's no loss, there's no CBD or THC left in that joint. You smoke it. So there is data to say that there's a mitigating effect, and there's pharmacology to back it up. This is an allosteric modulator CB1 receptors. We do have data to say that it's a really high concentration, but if you're smoking, it gets a lot higher, as we've seen in the studies. So it's reasonable to think that there is an interaction here. And what really makes this whole thing more complicated, and what really irks me about this, single molecule, we're not talking about one receptor. The pharmacologist mindset is this reductionist mindset that tries to put the most complex lipid signaling system found in nature, that interconnects all life with the spine, that interconnects all of your stimulatory and your inhibitory and your inflammatory and your immunosystems into this little box. It's like, oh, it doesn't flip that switch. It's like, this is an intertwined system, and we need to put away all this pharmacology. Certainly marketing we need to figure out, and we need to look at real human evidence and stop this nonsense where we're stuck on these little placebo-controlled trials, and collect data around humans. People are complex individuals. We need real science. Now, it has to go in concert with all of the stuff that's going on, and we've talked about.
Well, I don't think the only thing that's happening are placebo-controlled clinical trials. I can tell you that I've been a part of several post-market, observational studies where you're talking to human beings who are actually using it. And my clinic that I co-founded, Santé Cannabis, was part of the Quebec Cannabis Registry, which was a very large post-market surveillance pharmacovigilance study.
But nobody wants survey. Nobody wants them. They shut it down. What we need is large data. We need biomarkers. We need like longitudinal studies. We need real good science coming out. No one gives a shit about your survey. I mean, I didn't mean to say it that way. I do appreciate what you're doing, but you know what I mean.
Sure. Let's Peter, tell me why why is phytochemical polypharmacy unremarkable?
It's just like any polypharmacy. You put a bunch of active chemicals together, you're going to expect different effects than you get from any one in isolation, right? And there's all kinds of mechanisms that can explain this. You've got simple additive binding, antagonistic interactions, you got allosteric binding, lots of different methods that can give you some kind of synergism, the most obvious being induction or inhibition of metabolic enzymes. So all kinds of well-characterized pharmacological ways in which you can get additive or synergistic or canceling effects that you might want. The problem is that through these same exact mechanisms, and I think kind of seen this in some of these studies that I put up here, you can expect to get the exact opposite of what you want. And instead of getting mitigation of adverse effects and the amplification of benefit, you can mitigate those beneficial effects that might be there and amplify or augment the effects that you don't want. So there's nothing inherently about this. It's obvious. We know drug-drug interactions are a real thing, but there's nothing about this coming from a plant that allows us to say this is necessarily going to be beneficial. That's the problem I have again. And getting back to, I'm not denying that this entourage effect, these interactions exist. They're certainly there. My issue is with the way that this is presented in the marketing space of this necessary benefit. And you just don't know. And as Cody pointed out, until you actually look at a particular chemovar and quantify its effects, both positive and negative, you really don't know what these things are doing. Now, for a lot of general induction or introduction of these products, the commonly historically smoked or consume products. If the claim is, this is recreational and you can have some fun with this, yeah, you make an appropriate risk assessment for yourself. Like, all right, yeah, it's not probably too risky. You can self-dose. You can say, yeah, I don't like this. It gave me a panic attack. I'm not going to try it again. No big deal. But where I start having problem is when you've got this industry, it's a multi-billion-dollar industry that starts making these claims of you can treat your child's epilepsy, you can treat your cancer, you can treat this, and you are now starting to cajole people to walk a particular path based on what's convenient for you to make money off of. And by you, I mean an industry. So that's a problem.
Yeah.
Right. These are very real effects. And yeah, there's nothing remarkable about it. It's just, what are they actually doing? That's the big question.
That same problem exists in the supplement market. Like I agree. Yeah. Like it's almost the same. Like it's
yes,
so
yes, it does.
I can definitely see the the issues and concerns there. But going back to that, this is like a plant and an herb that we can lean into this idea that it is safer than a drug. So I don't want to like ever find ourselves in a place where we're treating the plant, which
but it's full of drugs. I hate that. I hate that characterization. It's a plant full of drugs.
Yep.
Right, but
right?
Listen,
opium's a plant full of drugs.
A drug is delta-8. A drug is a synthetically listen. I mean,
it's an arbitrary definition.
No, it's not. No, it's absolutely not. Sorry, Cody.
Yeah,
it's not.
It's an arbitrary definition
in the plant. Delta-8, Delta-9, HHC,
okay.
CBD,
right.
CBDV, THCV. Doesn't matter where they're synthesized. Doesn't matter if a man synthesized them. It doesn't matter if it was any gendered chemist, right? Like I understand that like it's an herb. I understand, but like herbs contain drugs. Herbs are not separate from drugs. We get all of our drugs from herbs. Salicylic acid comes from a plant.
That's not true.
Drugs are made.
That's an arbitrary designation.
No, follow me for 1 second. Walk with me, please. I think that we need to regulate the herb, the flower, differently than we're regulating these vape carts that are all over America going into these Delta-8 and HHC and all this trash that's being synthesized in a laboratory, different than we're regulating this herb and this flower. And that's the message that I'm trying to get to. So regardless of the diction, that's what I'm trying to say.
Yeah, I mean, I can appreciate a wanting to have different regulatory approaches for different types of products. All right. I mean, I can see some sense there. Again, particularly if you're going to legalize
classifications.
We do that in Canada, for example. Like all of our cannabis regulations. We have the Cannabis Act, right? The Cannabis Act. It regulates marijuana. It regulates hemp. It's all under the same thing. We don't have this crazy imaginary distinction between hemp and marijuana like in the US, where like hemp is just this magical non-cannabis that produces less THC than the marijuana. We don't have these absurd regulatory distinctions that turn into completely misinterpreted pharmacology. Like people take that regulatory distinction of hemp and cannabis and think that it's a scientific one, right? And then all kinds of arbitrary product regulation comes from that. I think only in America could you turn CBD into a precursor drug. Only in America could you turn something as like completely innocuous as CBD and turn it into a meth precursor. What I appreciate about Canada is we don't fuck around. If we have Delta-8 coming into the Canadian market right now, it's regulated under the Cannabis Act. It's federal, the quality is controlled. We're not calling it a pharmaceutical drug. We're not calling it a magical supplement. We're calling it cannabis, right? So I understand what you're saying, Cody, but
if it's THCO, THCPO, which is not coming from the cannabis plant at all. This is a drug, right? It needs to be regulated like a pharmaceutical.
Yeah,
sure. Let's agree on
if you want to make claims about it, a pharmaceutical. If you want to make health, if you want to make THC acetate into a pharmaceutical medication, yeah. If you want to make THC acetate into a recreational, non-medicinal product, I think there's different approaches to regulate that. I don't think that shouldn't be prohibited, for example.
Yeah, let's just,
but I digress.
Before we move on,
Yeah.
let's acknowledge that there is a long-standing, in any textbook of pharmacology, definition of what a drug is. A drug is any component that goes into the body that affects the physiology of the body, right? So it has nothing to do with where it comes from. It doesn't matter if it's synthesized, doesn't matter if it comes from a plant. Those are arbitrary distinctions. If you take something in your body and it affects cellular behavior, it affects your physiology in any way, that is by definition, any meaningful definition, a drug. So the entire dietary supplement industry is an industry of bullshit, right? It's just made up arbitrary legislative terms because the senators involved with putting the DSHEA into action in 1994 had very big ties to the supplement industry, right? That's all that really boils down to. It has nothing to do with the pharmacological reality of what you're putting into your body.
Yeah. And also in Canada, we take a different approach to supplements. I think the US approach to supplements is like, it's safe until proven otherwise. Go ahead and sell it until someone hurts themselves. In Canada, we don't have that approach. It's like, it's dangerous until you prove otherwise, and we're a lot more reticent about how we allow for supplements to be marketed. We're a lot more reticent around how we market tobacco and cannabis. I mean, I'm currently in Quebec where it's a complete state monopoly on distribution. You can't promote it. You can't even sell t-shirts with marijuana leaves on them in Quebec. We're so anti-promotional. Okay, like literally weed t-shirts were prohibited when cannabis was legalized in Quebec. But I digress. These are all great points. Let's try and we've got 5 or 10 minutes left. We've talked about, Cody, you've talked about like how pharmacology can be a bit reductionist. What do you both see as the biggest challenge in the future in terms of like, not just determining the validity or not of the entourage effect, but like, what's the biggest challenge moving forward in like, and just how do we design better studies? How do we educate the public about cannabis more effectively? I'll throw it to Peter first.
Yeah. So biggest challenges, real quick, as far as the reductionism thing, I mean, using reductionism as a pejorative, it's kind of borrowed from the supplement industry and a broader alternative health industry.
I didn't borrow it from there, but
I mean, it's been floating.
Oh no, but
it
is.
Time.
You didn't borrow it, but it is
right.
in the narrative. It's absolutely in the narrative.
It's there.
Yeah,
and it's real. It's borders on being an appeal to magic, to ignore pharmacological reductionism. These are very real processes and mechanisms that we know work, and any kind of interaction that you get from a full plant or a whole plant or full spectrum product can be explained, even though it's going to be really complicated. It can ultimately be explained. There's no reason to believe it can't be explained in terms of simple pharmacological interactions. Ultimately, if you want to bring something to market, do the clinical trial, prove that your specific entourage works, and then we can talk about the mechanism, right? And if you want to appeal to non-reductionist theories, knock yourself out. But I'm pretty sure I'll be able to explain it in terms of pharmacological interactions, and ultimately do the test, figure out if what you want to sell people does what you claim it does, quantify the risk, and then we can worry about the mechanism. So, all right. So just wanted to cover that with the reduction.
No, I want to chime in because I didn't really get to touch on this polypharmacology really quick. I mean, like,
go for it. Okay, so, 2 minutes.
So what Peter's saying is absolutely true, that we can try to explain it away, but we know these plants are often complicated, and we're finding things even in cannabis that we didn't know was there. A study came out yesterday looking at type 5 cannabis, which is THC and cannabinoid free. They found components that inhibit certain inflammatory lipoxins in the body. So just there's a lot of stuff going on in the pharmacology of plants. Second, if you look at the terpenes in cannabis and you want to look at their pharmacology, pulling from a little bit of non-injection sort of what do I want to say, essential oil studies, we see that limonene, D-limonene anyway, has some serotonin activity, 5-HT1A, the same receptor that SSRIs act on. We know that beta-caryophyllene, a terpene found in cinnamon, cloves, and many substances have CB2 activity, right? There's a lot of pharmacology going on that we can explain already that supports the entourage theory. Pinene has some anticholinesterase activity. Myrcene might have some COX activity in beta-caryophyllene too. CBD.
I think the big question around there is dose, though. I mean, like, there's not a lot of terpene coming in.
Yeah.
You know, I think we extrapolate a lot there. Like, well, there was a little drop of limonene in that 2-gram blunt I smoked. That must be why I'm feeling. You know, I think mechanistic explanations often overlook
100%
other shortcomings, right? Like, yeah, we have a mechanistic explanation and mechanistic hypotheses for a lot of stuff. I mean, and that's true in cannabis and in nutraceutical marketing too, right? Like, oh, there's a receptor.
So pivoting from that, I agree completely. Into the future, we need to let go of explaining. I agree. We're talking about an herbal product, and there's actually recently a rehashed FDA pathway for an herbal product to go through FDA approval and go through the process that Peter was talking about, which is a step in the right direction. It's still way too cumbersome and not effective whatsoever, too costly, et cetera. But there's a pathway there, and the caveat there, which is cool, and it ties right into this idea, you don't have to explain the mechanism of your drug before you get it approved by the FDA because it's an herb. You just have to prove that you're going to make it consistently and it works. And that is part of the pathway to the future for cannabis, in my opinion.
Yeah, the consistency becomes an issue there, though, right? I mean, because minor changes in the atmosphere, the soil, the lighting, the temperature is going to affect the terpene profile that comes out of these plants.
To a point.
And so, you know, what is within specs when small changes in the chemical makeup can lead to, yeah, I mean, so yeah, there are ways around this. Yeah. But one last real quick screen share that speaks to all this. So here's the drug discovery and development timeline for a normal pharmaceutical, right? There's a huge amount of attrition going from tens of thousands of compounds that you initially screen to get one that finally goes to market, right? And a lot of these things that end up being initial hits end up being false positives. One of the common reasons that they're false positives is for solubility issues. You end up getting colloid formation, which is known to interfere with just about any assay you throw this at in an in vitro setting. Much of cannabis research is still way down here in vitro and some early mouse studies, very small underpowered human studies every once in a while that are often not well designed, not because of ineptitude, but because it's very difficult to control against things like THC exposure. That's one huge problem here, right? Yeah. If you get THC exposure and you're trying to compare that to a placebo or to CBD, you know you've been dosed, right? So you're instantly unblinded. That's a big problem. The other problem is beyond THC, you have experienced users. You have people who can taste all the different terpenes, right? If it tastes like lemon, I'm going to feel this. If it tastes like pine, I'm going to feel this. If it smells like skunk, I'm going to feel this. So you've got these prejudices going into these things where people already know what they're supposed to feel, and that's what they're going to tell you they're going to feel. So again, we're way back here. The idea that we're going to get a useful product out of this, there's a reason why this timeline exists, is because most of these things just don't manifest as useful medications, right? And this extrapolation of in vitro data to say that, oh yeah, it treats this, it does this, historically speaking, you're guaranteed to fail, right? So that's one of my big problems here is you can't just look at some in vitro data and say, hey, this is really promising. In vitro data justifies going into a mouse. Mouse data justifies taking the next step, right? You got to get clinical human data to really know what you're talking about as far
to get approval. Not, I mean, to know what you're talking about in some ways, but we do have to guide consumers before we get FDA
but approval is based on study, research, general impression of safety, all that stuff
right now. So what are consumers and what are brands to do right now and into the future? Where do they go? Right? How do they advertise? You're telling them they can't use Entourage. We shouldn't use Indica Sativa. I'm just asking, like, where well,
I think there are FDA approved cannabinoids. And I mean, I'll make a point that I think that the Entourage effect myopicness, the myopia around Entourage effect only meaning superiority. What it's led to is people unwilling to take a 5 milligram THC pill. You know, people are they are absolutely opposed to taking Marinol. They're not going to take the Epidiolex because it's CBD isolate. It's created all of these toxic perceptions of pharmaceutically produced cannabinoids, right?
Can you imagine if people had a bad perception of pharmaceutical companies? And I wonder what they could have done to deserve that.
I'm not saying it's not warranted. I think the cannabis industry is paying for the sins of alcohol, tobacco, and pharmaceuticals. But like pharmaceutical companies and biotech companies also produce life-saving, hella important products, right? So like, yeah, we can wax about the evils of pharmaceutical capitalism for days, but like, we still need pharmaceutical products, and there's still rigor in that process that doesn't exist in the herbal supplement space, right?
They don't need record-breaking products year over year.
But what I'm saying is like, I've seen it. I've worked in medical cannabis clinics. Like people are like, nabilone, oh my God, no way. It's got one molecule. Fuck that. Oh my goodness. Oh, Epidiolex the FDA approved CBD product for my child with epilepsy. No, I'm going to go to the bud tender who's going to like whip me up some other bullshit. You know, like I think that's where the entourage effect stuff goes a little wonky, and it is where like cannabis as a nutraceutical supplement is extremely problematic.
Where I feel compelled to mention, I know at least 2 children with complex epilepsy that were tried on CBD and were unable to tolerate due to both side effects and ineffectiveness, that were then maintained on a full spectrum product containing CBG and CBD, and they were able to become seizure free for extended periods. So
is that a full spectrum product? I mean, like I've worked with dozens of pediatric epilepsy patients myself, and I know that like Epidiolex is not the be all end all of pediatric cannabinoids for epilepsy. Like I understand that, but like this idea that is because of, they used an isolate or whatever, like anyways.
The components of the drug probably do have a significant contribution to the efficacy of the medicine, and I am a firm believer in that. And I hope that we walk away from.
I mean, there's kids who manage their epilepsy with THC. You know, forget about CBG and whatever.
The ECS is amazing. Yes,
sure.
Yeah. So one quick point around all this that speaks to kind of the anecdotal aspect of all this. If you go back in time a little bit, the big topic, and Cody has made mention of this, was sativa versus indica. And people would swear they could tell the difference by the plant from morphological differences in the height of the plant, size of the leaves. And then they would swear that they could detect real differences based on whether they consumed one versus the other, right? And indica would be for, let me see, I got this written down, would be what for?
Indica's a downer, sativa's an upper.
Yeah. Right.
In the couch, thank you.
So but then, and there's been, things published on this. There was a survey by Pierce in 2014 that looks at this and says, yeah, people said that they can reliably tell the difference. Recently, there's been several papers that have looked at the difference between indica and sativa and found that there is no difference. You can't distinguish them chemically based on the morphological differences in the plant. More than that, there are even commonly used strains where you go from one state to the next, or one distributor to the next, one dispensary to the next, and they're different chemobars. Yet people swear that they can tell the difference between these things, but there's no reason to believe that they're getting different plants, right? Something that you think has high THC, low CBD may be entirely the opposite because nobody bothered to actually look. And just by looking at the size of the plant, they're assuming this, and then they're telling you, yeah, those are the effects I got.
So, and they overlook dose and biphasic effects and stuff like that.
Tolerance, time of day.
But the real issue is, if people swore by this for years, that this was a real meaningful distinction, how are we to accept anecdotal evidence of the entourage effect or the chemovar distinction these days, when it just is likely to be explained by these suggestibility issues? Right? People, you tell them what they're supposed to experience, they're going to tell you that's what I experienced. Right? You've got the same problems of nonspecific psychological placebo-like effects at play right now with these suggestions that, oh yeah, this whole plant or full spectrum treated me when this isolate did not, is no different than the situation of saying, oh yeah, I know indica works for this and sativa does this, but actually smoking the other one. Right? I mean, you've got the same problem.
we're coming to the end of it, but to both of you, to what do you think is the ratio in cannabis medicine between placebo theater and actual pharmacological effect?
Cody?
I think THC is a powerful psychoactive substance, and people derive a lot of benefit from it for many reasons. And often, I deal with CHS patients. They think they even can't live without it, right? And when you tell them that they have to quit, they feel like everything in their world has been taken away from them. Of course, this is a psychological addiction, and in a matter of a week or two, these individuals realize that they were probably addicted to cannabis. Now, so there's a lot to that, but this is the high THC talk, right? This is all marijuana. We've crafted this beautiful plant to make super high THC. I want to remind everybody that we've talked about Entourage and Terpenes. I'll be honest, I'm a pharmacist. I am cannabinoid first all day, every day. The cannabis plant, the name of the molecule, it's all because cannabinoid. It's not about the terpenes that you can find in every other plant. The cannabinoids are the magic molecules in this plant, and we need to leverage them first before we go off and saying that, oh, it's all about the terps.
Wait, if I have an endocannabinoid system, does that mean I should be consuming cannabinoids all the time?
All day, every day.
No, absolutely not.
You should eat healthy fats.
You also have an opioid.
It was a cynical question. Yeah, I use that line all the time. We also have that's my common rebuttal. Yeah, we also have an opioid system. Nobody's saying I should be smoking opium all day, even though I would like to be.
The name of the cannabinoid.
Sounds like a relaxing life.
It's an artifact of how these things are named in research.
How they were discovered.
Like needing these phytocannabinoids. I forgot the question.
Yeah, Peter, how much do you, to what degree do you think placebo theater versus pharmacological effect? Give me a ratio.
Absolute pharmacological effect from THC. There appears to be pharmacological effect from CBD, although I would tell you a lot of it is inhibition of metabolism, and it's not very clear that you get a direct pharmacological effect from CBD in treating things like seizures. A lot of data out there that makes it pretty.
Is that not clear? I mean, I would argue on that in that there's been like
that's definitely not true.
FDA approved. Like Epidiolex is on the market. It's gone through that whole.
And it's not mandated to be secondary. It doesn't have to be combined with another anti-epileptic. So you're saying the FDA is putting these patients at risk?
No, not necessarily. What I'm telling you is that all the clinical trials that were used to approve it for Lennox-Gastaut and for Dravet syndrome were adjunctive, right? You had these patients are taking an average of 3 other AEDs, anti-epileptic drugs. Some were taking up to 5 or 7 in some of these studies, and a lot of these.
But not all the trials were. Just the ones that were FDA approved.
So let him make his point, Cody. Let him make his point, Cody.
We're talking about FDA approval here, aren't we? You just brought this up. So the clinical trials used to get it approved, it's being used adjunctively, and the anti-epileptic drugs that it's commonly combined with, most notably clobazam, there is no clear interaction where you get increased plasma levels of these other anti-epileptic drugs when you give CBD, because CBD is a broad spectrum P450 inhibitor. It inhibits metabolism of these things. The data that's out there, even papers, and it's kind of like the Solowage paper that I brought up earlier. When you look at the abstract of papers by some of the people reporting in this, and they've actually looked into it, the abstract makes it sound like we've got clear evidence that it's not just this inhibition of metabolism, that CBD actually has some inherent value. But when you look at the data in these papers, I tell you that the data fairly clearly speaks to a drug-drug interaction, a metabolic interaction is responsible for the predominance of the effect of adding CBD to these regimens. It's very clear in the data, even though it gets interpreted as otherwise and pitched differently in these abstracts. So yeah, I would say. Well,
and like there are
I cannot sit here and
studies and patients. Hold on.
I'll send you the papers. Give me
chill,
another half
Cody, chill. Don't worry. I hear everything you're saying, and that's actually a fascinating point. That it's that the Epidiolex trials are entirely adjunctive. I'd not considered that, but like there are. I would say even though, anecdotes aren't highest quality evidence, like there are many pediatric patients managing their epilepsy only with cannabis and cannabinoids. Like I've worked with them. Like I know these kids.
There are countless animal studies. There are countless animal studies looking at seizure models. There are countless, these these, not the actual approval studies, these early phase trials that have gone through and shown benefit? Like,
I haven't seen any that are properly controlled though. There are a lot of
oh,
them.
come on, man.
No, I'm serious. These are
And it
very
works in
real
humans.
concerns.
So I'm telling you, I have a patient who's doing this, and you're telling me that because there's not a properly controlled trial that has shown that it's happening?
I'm telling you that there's plenty of reason to doubt anecdote. I just showed you with the sativa indica issue. And
I think
if you look at the clinical trials, you don't see these patients that magically their epilepsy disappears just with CBD. You get short-term remission in the combination products, but for some reason, when you actually have objective endpoints with physicians monitoring these things, instead of just parents and caregivers reporting on what they're seeing, and parents and caregivers can be affected by placebo effects just as much as the patient taking the medication. You look at the actual hard objective outcomes, and you do not see patients in these studies who their epilepsy goes away. The seizures don't stop. Why does it happen when you're not looking, but it doesn't happen when you are looking? These are very real concerns.
This is a subjective observer bias.
I think that
I'm tired, and
well,
I
think
appreciate your
those
opinion, but I am a compassionate caregiver, and I've seen what cannabis can do. And I'm telling you firsthand that cannabinoids have this benefit, and there's plenty of support to say it can work. I don't want an FDA approved trial. I just want access to the plant. But to say there's no mechanism, it's all metabolism, when kids are maintained on cannabinoids alone, is nonsense.
Show me a mechanism.
Oh my God, FDA approved it without a mechanism. If you look at Epidiolex, they say we don't know the mechanism. You're right.
Yeah, and you also have to appreciate the FDA has approved lots of things that have been pulled off the market aftermarket.
I'm aware.
Everything that goes through, just because it gets the FDA stamp, doesn't mean that it is gold and it works.
But dude,
I think there are gaps.
Guys,
chill. I think there are obviously gaps between, you can't take FDA approval or like a randomized double-blind clinical trial as dogma. In the same way, you cannot take a preclinical in vitro study as dogma as well. And both are liable to misinterpretation. Both can be subject to whatever placebo priming, placebo theater, expectations, all of that. But like, I think, and there are gaps between the experience of patients and clinicians and what we have in the literature for good and for better and worse, right? Like, I think I take your points, Peter. I was taken aback when you sort of said epilepsy and cancer in the same breath. Like, I hate the Rick Simpson people. I think Rick Simpson is a shitbag grifter and should not have his name on any cannabis product at all. He should not be held in reverence at all. He's killed people with his bullshit. But I was taken aback though when you said epilepsy in that same breath, given that like we've gone further in the research with CBD and epilepsy than we have with like these petri dish studies with cancer cell lines and stuff like that. When we're
and the context of that statement was looking at entourage claims of an entourage is going to treat your epilepsy or cancer. And the only reason I group those together is because those are very severe illnesses that need real treatment, right? It has nothing, one's not, the same as the other. And yeah, we definitely have better quality data out there for CBD and epilepsy. There's real data. And yeah, let me clarify.
Real patients.
This is the way that this should be handled. Yeah, you get FDA approval, and the FDA approval says that, yeah, you showed in a clinical trial that you had significant benefit relative to your control group, right? So that's there. How you got there, the mechanism how you got there isn't necessarily going to come out in that process. Usually it does, often it does, but sometimes it's not too clear. Aftermarket analysis becomes important. But what's really important with CBD and treating epilepsy is that you have people like Cody, and this is an approved agent. So you have physicians and pharmacists who know how to dose this. They know what adverse effects to look at. They know if there's drug-drug interactions. You can work with your patient, keep an eye on them, and have a safe and the most optimized treatment possible. That's how all this should be handled. I don't care what the real mechanism for CBD being useful in treating epilepsy is. I just threw that out there is that there's questions as to what it's actually doing.
Sure.
But ultimately, it has clinical utility, and you have professional healthcare providers who know what they're talking about, helping those patients along. The problem with the way that the market exists with the lack of regulation throughout the states is that, like you were pointing out earlier, Adam, if a parent is afraid of CBD because it's pharmaceutical and big pharma is evil and they believe all that nonsense, they're just going to go to the idiot down in the corner making stuff out of his garage. That's a huge problem. The fact that you can do that is a monumental issue, right? So I think we're all in agreement there. So yeah, again, my concerns with how it's actually working are, I think, legitimate, but it doesn't mitigate the clinical value that's been identified when it's used appropriately.
Yeah, I think also like getting into the nuance of where we are in evidence, I think there's such a knee-jerk reaction from the cannabis zealotry side that interprets anything negative or like any, oh, you got like even like mediocre results on something. Well, you must be a shill. This is a prohibitionist scam. Like there's such an ingrained victimization persecution complex in the cannabis world that like it's almost impossible to discuss these things with any degree of nuance to begin with, because there's always someone ready to be like, you're attacking me, you're just saying this to put me in jail. And it's true that like, it is true that a lot of the scientific a lot of the cannabis science has a harm bias because of prohibition, but that just doesn't, in the States it holds a bit water. It still holds water, but I think that stigma is disappearing, especially, but like I'm biased because I'm in Canada and it's just legal everywhere and we don't have Delta 8 gas stations.
Can I ask a question about kids? Like, let's say if a kid has cancer in Canada, how do they have to get their cannabis? Does it have to come from the CDA, the Canada Druggist? I know that's not a thing. I was just being facetious. Like, can they get plant? Do they have to get their card?
They can get plant. Yeah. So we have age limits on non-medical cannabis, but like there's no age limit on medical cannabis, right? Any person of any age can be authorized to access herbal cannabis for medical purposes. And then that lets them purchase basically GMP produced cannabis products directly from federally regulated supplier. So you can buy like Epidiolex equivalent products on our market.
In your cannabinoids and all that though? There's no like CBG or CBTA, etc.
No, I mean like you're limited in terms of like what's available from which producer you select, right? Like the minor cannabinoids just aren't as available as the other ones, but and it's on the healthcare professional to limit or not limit that authorization. So it's like, if a physician was authorizing a kid to use cannabis for whatever reason, cancer, epilepsy are usually the two. It's their prerogative to limit the THC potency. They can write on the medical authorization like you are not to sell this person anything with THC in it. They can limit it to just CBD,
or they can use it because they're healthcare practitioners and they can use fentanyl patches, so they should be able to also manage cannabis products.
Sure. I hate those. I honestly, like, I hear those comparisons all the time, but like, and fentanyl is so demonized too because toxic, unregulated fentanyl is killing people in the US. But like fentanyl, when it's properly prescribed, is a pain medication, that's widely used. I've had fentanyl during surgeries and stuff like that. It's a medication like any
use
other.
Of fentanyl during the peak of the opioid crisis, because that's not an appropriate use of fentanyl usually. Actually, no, really, Adam, they came down on them for using fentanyl post-operatively because they were mislabeling drugs.
No, it was It was during operatively. It was during operative.
Oh, of course.
It was not post-operative.
I use fentanyl every day. I use fentanyl all day, every day. Is why it came to mind. My point is this.
The what about is, like
I'm in the hospital, but yes.
You seem pretty active for someone who uses fentanyl every day.
No, we use it. Fentanyl is a tremendous drug. It has definitely infiltrated, but here's my point. It is a far more dangerous drug than cannabinoids, than any of the cannabinoids, as we know, and that's why it should, like, the physician should not be limited on THC. That was my whole point. That was all I wanted to say.
Sure, but like THC is also psychoactive, and
we don't limit physicians on any other psychoactive substance. Physicians should be able to practice medicine, and that's where I wanted to leave it.
Yeah, and it's an appeal to relative probation of it's not as bad as, it's not as bad as fentanyl, it's not as bad as alcohol, but I mean, we still have to contend with the actual effects.
Yeah, there's adverse effects. I just did a talk on CHS. I want everybody to watch it. If you're checking this out, YouTube it, my name, cannabinoid hyperemesis if you're interested in learning about it. I think we
I'm
have
so tired
to
of
talk about the
CHS.
adverse effects.
I'm so tired of CHS talk, to be honest, but that's just me. Check out Cody's talk on CHS.
So
Whoever's watching.
Adam, you brought up something about the shill argument. Like, if you badmouth cannabis, you end up
the shill gambit. Yeah.
Big pharma in pocket. There was a paper published last week that I stumbled across where a guy who's apparently getting an online PhD, right? That's a thing, out of some school in San Diego, who wrote a paper accusing me of being a big pharma shill in my Entourage effect paper that I wrote a few years ago. Now, there's a clear statement of conflict of interest in that paper. I received no money from anybody because it was library research. I didn't need to be funded. I have no affiliation with the pharmaceutical industry at all. And I don't want any, because I want people to listen to what I'm saying and not give me this shill bullshit. So people are publishing this stuff, which I'm pretty sure is libelous. So I'm kind of talking to the attorneys right now to see about getting this retracted. But yeah, I mean, it's out there. It's actually going into print. And the paper itself is kind of ridiculous. The guy doesn't actually say anything of any real.
Yeah.
But yeah, it's a very real thing.
Sounds like weed.
Yeah.
Yeah, the pendulum swings the other way too. We still definitely have some prohibitionists and some radicals on the other side. But hey, if we look around, pendulums be swinging really far in both directions right now. So
yeah, and the new prohibitionist is, borrows the language of progressives, right? The new prohibitionists like Kevin Sabet, it's all about, big cannabis is just like big tobacco. It's like, the cannabis industry didn't need big tobacco to shoot itself in the foot 100 times. The cannabis industry does it all by itself.
Big tobacco's still sitting on this land. Like, guys, when do you think we should get in? They're like, not yet.
Yeah. That's the big tobacco playbook to exaggerate health claims and this and that. It's like, cannabis people are doing that all by themselves.
Yeah, and a lot of it's being driven by, profit, right? They're trying to make money. So I love the follow the money argument. Look at the amount of money that's being generated. It's not concentrating in a couple of places because of how dispersed the industry is, although there is some aggregation going on. Yeah, I mean, it's about making money. And when you've got unfounded claims being used to make that money, that's a big problem. And there are a lot of unfounded claims out there, or not properly supported claims, as far as actually saying, give me money, I promise you what I'm selling you is going to do this, right? It's questionable.
Totally. Well, I like to call it the Entourage affect, personally. You go into the dispensary, you get a spiel about terpenes. That bud tender has a very well practiced Entourage affect. Well, I thank you both for the time. I could talk about this for hours. I feel like I'm perfectly between your positions here. Like I feel like I'm on the fence between either, your respective sides of this issue. And I come from the cannabis industry side as well. I've heard all of the zealotry. I've heard on the prohibitionist and the legalize it like fruit juice side, so I appreciate your perspectives. Thanks everyone for tuning in to to Cannabis 360 with the AAPS. And Cody and Peter, I really thank you enormously for your time. And if anybody has any follow-up questions, your contact information, I'm sure, will be attached to this video. And yeah, thanks for being here. Any final thoughts or last words you guys want to throw in there?
Yeah, I'll just say that I think we have a lot more overlap around the same page with some of the real big picture issues. And yeah, we can wrestle in the weeds about some details about, semantics and a handful of different things. But yeah, as far as big picture of where we need to go with this, of making it available and safe, because that's the reality. I mean, you can't stop the freight train. It's being used. You got to acknowledge it. And the prohibition has been preventing meaningful study for decades. Huge problem. That's got to go.
Absolutely. And I want to agree. First of all, I met Peter once before we were at CanMed. We had a sizzling conversation around this, and they kind of rolled into this one. So thanks so much for being a good mate, and Adam for your hosting. And I guess just to build on that, I agree. Big ticket items. We need to get healthcare professionals involved. We need to get patients, make sure they're getting clean, not tainted products, and we need to get education and marketing claims sort of managed.
Did I medicate my child's epilepsy with a Delta 8 vape from the gas station?
HHC is actually what's been shown with cinnamon terpenes.
Yeah. Thanks
Oh,
again.
the botanical terpenes. The botanical terpenes. I love that spin. Yeah. Anyways,
yeah, bad
thank you both. I
closer,
really appreciate it.
Good seeing you,
seriously,
Tony.
thanks, guys.